it's a little bit of a revision of the same. And most important is to see things a little from a lateral point of view, like how the various structures that go on to form the knee has got relevance in chronic pain. So that's the topic for me today, to understand the relevance of anatomy and sonoanatomy of muscles at the knee in knee pain. Yeah, next slide. Next slide. Okay. So, am I audible? Can I continue? Hello.
Yes, you are audible.
Yeah, all right. So let's revise the bony landmarks that are palpable. So the medial condyle of the femur, lateral condyle of the femur, patella, the medial condyle of the tibia, the tibial tuberosity, and the head of the fibula. Now, going on to the muscular landmarks that are palpable. So you have anteriorly above the patella, the quadriceps muscle that can be palpated. On the medial aspect is the bulk of the sartorius gracilis and semitendinosus that goes on to form the pes anserin, and the iliotibial band laterally. Below the patella, on the inferior medial aspect is the subcutaneous plane. It is devoid of any muscles except for the attachment of the pes anserin tendon. And laterally, you've got the bulk of the tibialis anterior and the peroneus longus. Posteriorly, above the popliteal crease, what's palpable is the bulk of the medial and the lateral hamstrings. And below the popliteal crease is the bulk of the gastrocnemius muscle. So the caveat here is the muscular landmarks that are palpable are not exactly the anatomically aligned muscles. We all know that the lower extremity is specialized for two important functions, which is giving support to the body and enabling locomotion. Developmentally, the lower extremity bud undergoes permanent medial rotation of the proximal limb, bringing the extensors of the knee, ankle, and toes anteriorly, with the knee pointing forwards. So, muscles on the anterior aspect of the lower extremity are extensors at the respective joints. Like, for example, the quadriceps, which is on the anterior aspect of the thigh, is the extensor of the knee joint. And the muscles on the posterior aspect of the lower extremity are flexors at the respective joints. For example, the hamstrings and the gastrocnemi, they flex the knee. Now, it would be hard to imagine if this lower limb bud had not gone the medial rotation evolutionarily, what would be our gait? Most probably we'd all be walking with a waggling gait. So a quick revision of the muscles of the lower extremity pertaining to the knee. So on the anterior aspect, the muscles do not arise from the knee area specifically, but they arise from the pelvic bone as well as the femur. So that's why the heading is muscles of the front of the thigh with respect to the front of the knee. So the main muscle is the quadriceps muscle, which has got four heads. The first head is the rectus femoris, whose proximal attachment is to the anterior superior iliac spine. The next is the vastus lateralis, which is attached to the greater trochanter, the lateral aspect of linea aspera. Linea aspera is the line that attaches the joints, the two trochanters of the femur posteriorly. The vastus medialis is the third head, which has got attachment to the intertrochanteric line, the lesser trochanter, and the medial aspect of the linea aspera. The last head is the vastus intermedius, which arises from the anterolateral aspect of the shaft of the femur.
Renuka,
While these are the proximal...
Renuka,
yeah, tell me, ma'am.
Renuka, I just want to butt in here a little. So please note that the vastus lateralis is arising from a posterior structure, that is the linea aspera, the upper and the lateral aspect of linea aspera. So the vastus lateralis is not exactly lateral, but it is posterolateral, lateral, and anterolateral. So vastus lateralis is the muscle which sort of wraps around the thigh from the lateral aspect, both to the front and the back. Yeah, please carry on, Renuka. I'll keep butting in now and then.
No problem, ma'am.
Yeah.
So the fourth head, vastus intermedius, is proximally attached to the anterolateral aspect of the shaft of the femur. Now, the distal attachment of all these four muscles go on to form the quadriceps tendon or the patellar tendon, which is attached to the base of the patella and the tibial tuberosity. Now, the understanding of this, the attachments of the muscle has got an important bearing on understanding the soroanatomic alignment also. Like, for example, now the four heads of the quadriceps is arising from two bones, the pelvic bone as well as the femur. So the muscle which is attached the last or the lowermost, like in amongst these four heads, vastus intermedius is the muscle that is attached to the anterolateral aspect of the shaft of the femur, and it is the lowermost structure to get attached between these two bones. So you can expect that at the distal attachment, this muscle will be closest to the bone, whereas rectus femoris, which is attached proximally to the pelvic bone, will be the superficial most. Moving on to the muscles that are on the medial aspect of the front of the knee, you have the sartorius, whose proximal attachment is to the anterior inferior iliac spine, and the gracilis, which is attached to the pubic symphysis, the inferior pubic rami. The distal attachment of these two muscles, along with the tendon of the semitendinosus, which is a posterior structure, go to form the conjoint tendon of pes anserin and gets attached to the anteromedial aspect of the tibia. Moving on to the muscles that are at the front of the leg. Do I have to stop, ma'am?
Yeah. See, I just wanted to emphasize, look at the beginning and end of sartorius. It is starting with the most lateral muscle where it starts, and it inserts into the most medial aspect in the pes anserin. So as a result, this is a muscle which is doing almost an impossible task of working across the thigh to bend the knee. So as a result, this is one of the very stressed muscles, and it is also a very small muscle compared to the quadriceps and others. So as a result, the sartorial pain is very, very prominent in all OAD pains, because this is a muscle by evolution has gone from somewhere to somewhere else, and it is not doing the work that it was intended to do when it was first introduced by nature. So this is in fact, in most of the post-TKR pain, in many post-OAME pains, it is the sartorius which is always most affected. It is the design defect. Levator scapulae, piriformis, sartorius are all design defects of nature. We can't call it design defect so much as our own, what shall I say, our own overreaching to stand up straight from quadruped position. Okay? Yeah, that's it. Please carry on.
Yes. So moving on to the muscles at the front of the leg and therefore at the knee, there is the tibialis anterior. Now the tibialis anterior is proximally attached to the lateral aspect of the lateral tibial condyle, the anterolateral aspect of the shaft of the tibia, the anterior aspect of the interosseous membrane. And the distal attachment is to the medial aspect of the medial cuneiform bone and the medial aspect of the base of the first metatarsal. The next muscle is the extensor digitorum longus, which is again attached proximally to the lateral aspect of the lateral tibial condyle and the upper three-fourths of the anterior aspect of the interosseous membrane. Distally, the tendons get attached to the base of the middle and the distal phalanges of the second to the fifth toe. On the lateral aspect is the peroneus longus, whose proximal attachment is to the head of the fibula, the upper part of the shaft of the fibula, and distally, the tendon takes a long route to cross from the lateral to the medial aspect of the plantar aspect of the foot, getting attached to the lateral aspect of the medial cuneiform bone and lateral aspect of the base of the first metatarsal. I'm sure it's a little confusing, so we'll just focus again on the distal attachment of the two muscles of the leg, that is the tibialis anterior and the tendon of the peroneus longus. So the tibialis anterior distally gets attached to the base of the to the medial aspect of the medial cuneiform bone and medial aspect of the base of the first metatarsal. Likewise, the tendon of the peroneus longus is attached to the lateral aspect of the same bones, that is, the lateral aspect of the medial cuneiform bone and lateral aspect of the base of the first metatarsal. So what we are understanding is that the insertions are to the same bones, but on the opposite sides. While the tendon of the tibialis anterior takes a perpendicular attachment, the tendon of the peroneus longus is like a stretched pulley traversing from the lateral to the medial aspect of the foot. So herein you can imagine that repetitive strain injuries of these muscles can cause issues at the distal attachment. So again, a pain generator. So this is what Madam was trying to highlight, how the muscles start at one point, traverses either straight, diagonally, or takes a posterior dip, and all to create issues for chronic pain physicians.
Here again, I'll put in Renuka.
Yeah, yeah, ma'am.
One of the things you also have to look at, just now Renuka has outlined that on the medial aspect of the cuneiform bone is and the first metatarsal is the tibialis anterior. And on the lateral aspect, your peroneus longus. Okay, they are doing it. But peroneus longus is also getting a slip to the the last metatarsal at its tarsometastarsal junction. So this is one aspect. It is spreading itself out. Both the peroneals work together. So as a result, it's going to, this is a tendon, conjoined tendon, which is going to the lateral aspect of the leg, the medial aspect of the leg to form the arch of the foot. But in addition, peronei are pitted against two big muscles like the tibialis anterior and tibialis posterior, because tibialis posterior is also coming to the medial aspect of navicular. Right? So as a result, there are two inverters and there is only one inverter. So inversion is a more powerful action. All said and done, our foot is placed flat on the ground. That means for avoiding eversion and inversion, the inverter is stressed out a lot. So as a part of functionality, peroneus is duped. It is pitted against two of them and its insertions are going in two different directions. So that is the reason. Okay. Yeah, please, Renuka.
Yes, ma'am. So moving on to the muscles at the back of the thigh and therefore at the back of the knee, you have the hamstrings. So the hamstrings are proximally attached to the ischial tuberosity, and it has got two components, the medial hamstrings and the lateral hamstrings. The medial hamstrings has got two muscles, the semimembranosus medially and semitendinosus laterally at the proximal attachment. Distally, the semimembranosus, for some evolutionary reason, becomes lateral to semitendinosus and gets attached to the posterior aspect of the tibial condyle, while the semitendinosus, the distal attachment, the tendinous attachment, conjoins, as I told you earlier, with the tendons of sartorius and gracilis to form the pes anserine. The lateral hamstring comprises of the biceps femoris and is proximally attached to the lateral aspect of the ischial tuberosity, and distally it is attached to the head of the fibula. Moving on to the muscles at the back of the leg at the knee. Superficially, you have the medial and the lateral gastrocnemius muscle, whose proximal attachment is to the posterior aspect of the femoral condyle. The distal attachment, well, the tendons of both the heads fuses together to form tendoachilles, which is attached to the posterior aspect of the calcaneum. At the intermediate layer is the soleus muscle, which arises from the back of the head of the fibula and the soleal line of the tibia. The distal tendinous attachment fuses with the tendinous attachment of the gastrocnemi, that is the tendoachilles, and gets attached to the calcaneum. At the deeper level, you have got the popliteus muscle, whose one of the attachment, it is analogous to the pronator teres of the upper limb. So it's an oblique muscle, short muscle, where one attachment is to the posterolateral aspect of the femoral condyle, the lateral condyle, and the lateral meniscus, whereas the other attachment is to the soleal line of the tibia. Now, this attachment to the lateral meniscus probably explains the locking of the knee when there is injury to the lateral meniscus. So it pulls or it sort of straddles the femoral attachment of the popliteus muscle when there is flexion or extension of the injured knee. So it's also important to understand the cross-sectional view of these muscles, because this is how you see in the sonoanatomy when you place the transducer on the area of interest. So this is a cross-section of the knee at the lower one-third of the thigh. Let's identify the femur. So the structures, there are two compartments, structures anterior to the, let me see, try if I can annotate it. Yeah, so there is the femur, and there is an anterior compartment and the posterior compartment. From lateral to the medial aspect, the structures are vastus lateralis. The closest to the femoral shaft is the vastus intermedius. Superficial most is the rectus femoris. Medially, you have got the vastus medialis. Medial to vastus medialis is the sartorius, and the medial most is the gracilis muscle, which is not shown in this picture. Posterior to the femur lies the posterior compartment, where laterally is the bulk of the short and the long heads of the biceps femori, and medially you've got the semimembranosus and semitendinosus. So these are the sonoanatomic picture. So you can see the, I think I again lost later the, anyway, the hyperechoic line with the anechoic shadow is the femur. So the muscle which is closest to it and above it is the vastus intermedius. More superficial to it is the rectus femoris. When the transducer is moved medially, you see the bulk of the vastus medialis labeled as VM here. And medial to vastus medialis is the bulk, the small bulk of sartorius muscle, and the medial most sartorius in figure E is the gracilis bone. I mean gracilis muscle. Moving on to the cross section at the upper one third of the leg, we can identify the two bones first, the tibia and the femur. The structures anterior to these two bones from tibia to the fibula includes the tibialis anterior, followed by the extensor digitorum longus and peroneus longus, that is also called as the fibularis longus near the fibula bone. In the posterior compartment, you have the popliteus muscle at the deeper level, followed by soleus at the intermediate level, and the medial and the lateral heads of the gastrocnemius at the superficial level. This would be the sonoanatomic picture. The first figure onto the left, let us identify the bone, the hyperechoic line with anechoic, that would be the femoral shaft. So above that is the lateral hamstring. The next picture shows the sonoanatomic picture of the medial and the lateral, the semimembranosus and the semitendinosus. And the lowermost muscles, we could identify again the two bones on the right side of the third picture. Superficially, you got the fibula, and at the deeper level, you got the tibia, and the muscles that are attached from the bone towards the upper end is the soleus and the gastrocnemi muscles. Now, what if nature had not given the skin, the muscles, ligaments, etc.? Then it would be completely bone on bone. But we know that the knee joint is a hinge joint, a synovial bicondylar joint that fulfills excellent functions of flexion extension, gliding, rolling, medial and lateral rotation. So would it have been possible if there were no muscles and ligaments? Not so. So it's important to imagine the musculorymatic composition and the architecture at knee, taking the analogy of a house construction that explains the foundation of the stability this joint gives. So the construction of a house starts with putting of a foundation. So at the knee, the lower extremity bud it starts growing. Then comes the placement of the plinth. So probably that is analogous to the bones of the knee. The next stage in a house construction is putting of the pillars and beam. Well, at the knee, you got the various ligaments and menisci. You got the anterior posterior cruciate ligaments, the tibial fibular collateral ligaments, the medial lateral meniscus. Then you got the retinaculae, that is the tendinous insertion of the various muscles. Then comes the building of the walls for the house, the final structure that gives stability to a house. Well, we have the muscles, as all has been discussed in the previous slides. Well, the plumbing comes on. Now, this is the complex vasculature of the knee joint. There's so much of the fallback mechanism placed there by nature. And well, the house cannot be well lit without the electrical connection. And we all know the complex innervation of the joint, the knee joint especially. Well, the figure itself looks very complex, and I would take the opportunity to revise it myself. The innervation of the knee. So superolaterally, it is innervated by the superomedial, superolateral genicular nerve, which is a branch of the femoral nerve.
Switch on your video, please.
The common fibular nerve, the nerve to the vastus intermedius, and the lateral branch of the nerve to the vastus intermedius.
Excuse me, ma'am, can you hear us?
Superomedially, sorry?
Can you switch on your
Hello?
video, please? Because we want to
My
record
video.
this picture.
Go back.
I don't know how to do that. I will probably have to go back. What do you want me to do?
Bottom left,
Sorry?
unmute option. Where you can unmute, you can start a video also.
I'm sorry, I'm not able to understand what I'm being told.
The leftmost bottom of your page, there'll be a mute unmute option. Just besides that, there will be a video option. So you can activate the video.
No, I have to stop sharing the screen, I think, isn't it?
No, it can upload simultaneously. Screen sharing, let it go.
Huh?
Screen sharing, let it go on. Just lowermost button here.
I think I'll have to.
It's okay.
Okay, 1 minute. To drop. Okay.
Okay, no
Let's start
problem.
with video.
Sir,
Is that okay? Is that okay?
Yeah, ma'am, you can continue, no problem. No issue, ma'am.
Yeah, I think I'll continue. So,
Wow.
so we're talking about the complex innervation of the knee joint. Okay. So superolaterally, it is supplied by 4 nerves. Superomedially, it is innervated by the superomedial genicular nerve, which is a branch of the femoral nerve, and the nerve to the vastus medialis, as well as the medial branch of the nerve to the vastus intermedius. Moving on to inferolateral compartment, it is supplied by 2 nerves. One is the recurrent fibular nerve and the inferolateral genicular nerve. Inferomedially, it is supplied by the inferomedial genicular nerve, a branch of tibial nerve, and infrapatellar branch of the saphenous nerve. Now, with this around 7, 9, 11 nerves innervating the knee joint, can chronic pain be away? Unlikely. Also, I have not included the popliteal plexus. So add on to that, it will be about 10 to 11 nerves. So finally, with all the beams and pillars and walls and whatever, a beautiful house is built. Likewise, a well-toned well-toned knee is formed. Now, this concept, the
Renuka,
musculo-rheumatic, yes, ma'am.
Renuka,
Please go
can
ahead.
you
Please go ahead. Please go ahead.
recap the nerves of the knee? Because I think I want it to sink into everybody's head. Just go through the innervation, the 7 nerves which you mentioned.
Yeah, okay, ma'am. So the knee joint capsule is densely innervated. So let's divide this anteriorly into 4 compartments: superolateral, superomedial, inferolateral, and infiromedial. On the superomedial, it is innervated by 4 nerves. One is I'm sorry, did I say superomedial? I would start with superolateral. I don't know what I said. On the superolateral aspect is innervated by 4 nerves. The superolateral genicular nerve, which is a branch of sciatic nerve. Second, the common fibular nerve. Third, the nerve to the vastus lateralis. Fourth, the lateral branch of the nerve to the vastus intermedius. This is the innervation of the superolateral portion of the knee capsule, knee joint. Let's go on to the superomedial aspect. 3 nerves here. The medial branch of the nerve to the vastus intermedius, the nerve to the vastus medialis, and the superomedial genicular nerve, which is a branch of the femoral nerve. Let's move on to the inferolateral aspect. 2 nerves here. The recurrent fibular nerve, branch of the fibular nerve, and the inferolateral genicular nerve, which again is a branch of the fibular nerve. Lastly, the inferomedial component, which is innervated by again 2 nerves, mainly by the inferomedial genicular nerve, which is a branch of the tibial nerve, and variably the infrapatellar branch of the saphenous nerve, which in turn is a branch of the femoral nerve. The posterior aspect is innervated by the popliteal plexus, which is formed by the tibial and the fibular nerve. And to some extent, there is a contribution of the posterior division of the obturator nerve. So the main nerves are femoral, obturator, and sciatic. Rest are all the branches of these three nerves. Can I move on, ma'am?
No, I want to elaborate a little here. So
Yeah.
if you have seen this complexity of innervation, you know, the genicular nerve RF, whether you do thermal RF or whether you do cooled RF, is only addressing 1/4 of the innervation of the knee joint. And we hope to get rid of all the OA knee pains by doing genicular nerves. It is rather ridiculous to think that just doing burning of the genicular nerves will take away all the pains. So that is the reason why I wanted her to enumerate it again. And in the four corners, we are ignoring the inferolateral corner altogether in the genicular nerve RF procedure. Simply because it is too close to the common peroneal nerve. And if you fiddle around with the common peroneal nerve, you will get a foot drop. So one out of the four genicular nerves, we are ignoring the inferolateral nerve altogether. We are addressing three of the genicular nerves. And we are ignoring the contribution to the vastus lateralis, the vastus intermedius, the vastus medius, the sartorius, the infrapatellar branch. All these we are simply ignoring. So it's a very short-sighted view about which nerves you are targeting in genicular RF procedures. Yeah, please carry on now, Renuka.
Lakshmi, you remember the diagram I did in which the PRF was shown? That will highlight where all you can do the PRF. Remember those three diagrams?
Yeah, but so we don't have the diagram. I will probably highlight it later.
I have the diagram on my PPT.
Yeah, you can share it. I don't know.
It's already
She's
there.
already showing the diagrams actually.
I've already shown it. It's there in the PPT. Anyone can see it.
Yeah. Yeah, after Renuka's, we will just get 1 minute of your slide.
Shall I proceed?
Yeah, please, Renuka.
Okay, moving on from the picture of beautiful house and well-toned knee. So what we have to understand is that the concept reproduces itself at every musculo-rheumatic junction of the body. And disturbance in each structure imbalances this equilibrium. And thus we have the various problems of chronic pain, repetitive strain injuries of muscles and ligaments, painful degenerative conditions like osteoarthritis, bursitis, complex regional pain syndrome, painful healed hematomas. So is there some rule that connects all these dots? Well, evolution has given that architecture, but it was left to Hilton, the scientist, to give us that rule, linking all these structures. So what Hilton's law states is that a joint in the body tends to be innervated by a branch of a motor nerve, which also supplies a muscle extending and acting across it. Let us take the knee joint. So the knee joint is innervated by the branch of a motor nerve. Let's say the muscular branches of femoral nerve. Well, the muscular branches of the femoral nerve, that is the nerve to the vastus medialis, vastus lateralis, vastus intermedius, also supplies the muscle. And another branch of the same nerve often supplies the overlying skin. We know that there are branches of the femoral nerve which has got cutaneous supply. The anterior cutaneous nerve of the femoral nerve, the saphenous nerve, etc. So this is the last slide. What I would like to emphasize is that so far we have focused on the bones, the muscles, the ligaments, the menisci, etc. But there has to be a small thought given to the muscle fibers in these muscles. like the muscle fibers in the muscles that act on the knee belong to the category of type 2A and type 2B. The type 2A fibers are the fast oxidative fibers. That is, they have got moderate amount of myoglobin. Myoglobin is the hemoglobin of muscle. It is required to kickstart the mitochondria to produce the ATP that ultimately produces the energy to bring about all the movements of the body. So type 2A fibers are the fibers that has got moderate amount of myoglobin and moderate amount of mitochondria. Therefore, they develop tension quickly, but they don't sustain for long. These are the muscles we typically use for the movements brought about by the knee, like brisk walking and so on. The other type of fibers is the type 2B, which are referred to as the fast glycolytic because they have got very sparse amount of myoglobin and very sparse amount of mitochondria. So the energy generation takes place by anaerobic glycolysis. So this is what comes into action when one is sprinting. So the composition, the understanding of the type of the muscle fibers also help us to understand what injuries can do to these muscle fibers and how they will get affected to cause pain, notwithstanding the effect of degeneration ongoing because of long-standing diseases like hypertension, diabetes, dyslipidemia, hypothyroidism, trauma and healing, and most important of all, aging. So what one to understand and remember is that though the composition of the muscle fibers is genetically determined, degeneration can bring about the change in the percentage composition of these muscle fibers. And training, however, can selectively strengthen the percentage composition of these fibers. So this will further enable us to understand the impact of hypoxic injuries on in the muscle because of various diseases, and how dry needling or any other treatment modality that addresses muscles can help in relieving pain. So these are my references, and I wish to thank Madam as well as the organizing team for giving me this opportunity to talk again on this pet topic of a topic of mine. We even have a publication as Mary Madam was referring to, and it's quite heartening to know that it has been cited pretty well. So thank you all. Hope you have a very great learning session today.
Thank you, Renuka. It is cited very well, but not followed
Thank
very
you,
well. I don't think anybody else is doing it other than our own people.
Okay.
We'll have to leave the meeting and log
Any
in again.
question? Questions, any of you?
Certain ligament and muscle, then they are on the joint. How close they are and can they affect each other? Like medial collateral I didn't start. Okay, you can talk to me.
No. You address it to her and then I will come. Renuka will have her one.
I'm just able to hear Madam. I
Hello,
was
Renuka.
not able to hear the. Yeah. Hello.
Hello.
Yeah. I'm able to hear. Tell me.
Yeah, actually, I just want to ask how there is a much close relation it exists between the collateral ligaments and the tendons of the muscles which cover the knee joint. Like this is basically pes anserin and the medial collateral ligament. Medial collateral ligament has two layers. One is very adherent to the capsule and the superficial. So can they? Is there any correlation?
Correlation with respect to metrics, I do not know.
Pain.
But to the pain. Did you say pain?
Yes, she did.
Okay. Yeah, there is correlation to pain because all these structures bring about the movement. Like, see, the closest to the bone is the menisci, the collateral ligaments, and the cruciate ligaments. And this is enclosed by the fibrous capsule. Then you've got the synovium. Then you've got the attachment of the various muscles. And most of these structures, whether it is the ligament, the menisci, or the muscles, they subserve the same functions of the knee joint. So, direct injury to the ligaments and the menisci can be one source of
Yes.
pain. And when that happens, there is an overloading onto the muscles which subserve the same function, so they can be affected. Or vice versa, if you take some long-standing diseases, as I mentioned, the hypertension or a long-term healing secondary to some trauma or the complex regional pain syndrome or whatever it is, there are hypoxic injuries at the muscle level. So there, whether it brings about the component of the ligament and the menisci, if they are normal base in the baseline situation, that I cannot comment on. But this is how we will have to think laterally and start linking.
Yes, I think even the medial collateral ligament, sometimes the laxity can also produce the pain, which has to be addressed separately
Yeah. So
along
that
with the
depends upon
muscles.
what the pain generators are. Even if the medial collateral ligament is injured and is the cause for pain, now the function of the knee is subserved by the overaction of the medially placed muscles at the knee. That could probably be the vastus medialis, which is an extensor, or it could be the component of the sartorius gracilis tendinosus, which is a flexor. I mean, which is the extensor, which is a medial, which is an adductor, and as well as a flexor. And posteriorly, you've got the adductor muscles, which is a flexor. So that's the way you'll have to see the whole, the whole picture probably.
Yeah. Are you done, Renuka?
Yeah, ma'am. Yeah.
Yeah. See, you are looking at contrasting functions here. Your medial collateral ligament or lateral collateral ligament, it is providing the stability. The muscle is providing the stability as well as the mobility. That is the difference here. Let us say you have hypermobile muscles. To maintain the stability of that knee, the medial collateral has to be in a state of little more tension than otherwise. And if the medial collateral ligament is lax or injured, then there can be sudden hyper movements of, because the muscles are dominating, at least, which produces pain. So these are complementary as well as opposing actions of ligaments and muscles. Muscles are stabilized, but at the same time they are more for mobilization. The ligaments are stabilizers in that they limit movement, but at the same time they are allowing movement as well. So there is with the ligament, it is thus far and no further. And muscle is this much more far and no further. Yeah. Does that answer you? Or
I think we have to address everything whenever we are addressing.
yeah, there is no choice. And when we are needling, I do believe that we are hitting the medial longitudinal ligaments many times. Because we try to go in as much as possible. I'm sure we are grazing it or even going beyond it. So, and all said and done, the ligaments are again elastic structures, which is like a rudimentary muscle meat. It's got the same elastic component which can relax, like the fascia. Fascia limit the muscle, and the ligaments will limit the joints.
I think one of the
Yeah, anybody else wants to say anything? Renuka, you want to come in?
Yeah. one of the limitation is that we sort of empirically say when we're doing dry needling, it will go through the fascia and ligaments to some extent. But what the person who asked the question, I'm sorry, I don't know the identity, is probably we do not have the knowledge of ligamentous sonoanatomy. That would be perhaps down the 10 years down the line. Right now, we are just focusing on the muscular sonoanatomy. But when you do the intra-articular injection, you do see the medial menisci, the lateral menisci, and things like that. It's just that we have to improve our learning curve on identifying these structures on the ultrasound. But I'm sure, as Madam said, we do pierce these structures. Because where is the medial collateral ligament? It is between the tibial condyle and the medial femoral condyle. Where is the fibular collateral ligament? It is a stretch structure connecting the lateral tibial condyle and the lateral femoral condyle. So when we are doing so, it's quite possible that we are piercing these structures.
Yeah.
That's it, ma'am, from my side.
Any other questions? Anybody? Too much overload? Yeah.
Madam, regarding the types of fibers which you mentioned, so do we have any data as in which muscle contains how much proportion of type 1, type 2A, type 2B fibers? Because then we could focus on that particular muscle. Like if you say that type 2B fibers are more susceptible to oxidative injury, then if we already know that there are particular muscles which have higher proportion of 2B fibers, then kneeling could probably focus on those muscles more, which could probably give better results. Is that possible? Is that a thing?
Yeah, that is the thing. And I do not have any ready data. I tried reading quite a bit, and this is all I could put it in a nutshell. I think it is an individual interest to take it on. I've thrown the thought, and probably I hope the seed germinates in all your minds how to go about it. Like type 1 fibers is the postural muscle fibers, which is they are the slow oxidative fibers. They've got abundant myoglobin, abundant mitochondria. So the energy production is that great, and therefore it helps in maintaining our posture, like the axial musculature. Musculature, like the erector spinae, the psoas, the quadratus lumborum. These are the examples of type 1 fiber. So this is just an idea thrown how we will have to look at things at micro level, perhaps. And that will certainly help you understand the basis of dry needling also. Because dry needling is a technique which, shall I just complete it, ma'am?
Yeah, please. I thought you.
Yeah. It just came as an afterthought. So when you do dry needling, you are creating a micro trauma invariably. Micro trauma causes micro bleeding. Now, studies say that internal bleeding always has got healing factors, also myogenic factors. So it is one way where the new muscle fibers grow. And when they grow, probably we can keep our fingers crossed that they are more of type 2A and type 1 rather than type 2B. So there's a very good book by Changan with Madam in the library. I think some of the thoughts are still relevant, what this person has mentioned in his book. That's all, ma'am, from my side.
Okay. I feel that probably the muscles closest to the bone, like the vastus intermediates amongst the quadriceps, and there are the deeper fibers will be the ones involved with posture. So they will probably have type 1 fibers. The more superficial ones will be the type 2A and 2B. Probably, if you do a selective kind of deep needling, you cannot really select because you have to go through the superficial fibers. But when it comes to strengthening exercises, today we don't have the physiotherapist girl, otherwise she might have helped. In the strengthening, if you do the deepest muscle fibers, that may help better in sustaining the things. But when it comes to an athlete who wishes to run, he doesn't really need more of the sustenance of the posture. What he needs is immediate changing, rapid changing postures all the time. So for them, a different kind of strengthening will be needed, different kind of endurance will be needed for them. And I think all these fellows should just do something like a blanket needling every week or every 10 days or something like that. But if we propose it today, they'll think it is business promotion. But it is actually something which is going to be very useful in the long run. As the sports physiotherapists take it up and probably insert one, two needles in each muscle, very precious muscles of athletes. I think that might work better, but this is a study which needs to be done. And then we'll have to see
I
where.
think there is a difference between acute pain and chronic pain. In
This
acute
is-
pain, madam, either they respond extremely well. That is
Yeah.
acute spasm.
Yeah, but the thing is, you are talking about athletes who do not know what is pain and who deny pain to achieve more and more. So they will never tell you मेरे को pain
But they are
है.
quick responder, madam.
Ah,
They-
they are very quick responders.
Because I know, I'm treating her, she is a national, international level swimmer, and every now and then she gets some
Yeah.
muscle aches and things. The moment you do even single needling therapy session, and she's gone.
They will do well.
It's a heavy overloading over, you know.
So what you are doing is the maintenance,
Yes,
basically.
yes, absolutely.
So which she should do all the time
Yes.
and which all athletes should
Because
do.
there are going to take medicine and many medicines are forbidden in the actual competition.
Yeah,
So this is the best therapy.
for them. No, this is the best therapy for all
But what she's
athletes.
saying is now the key thing is the cupping.
Yeah.
Everybody will have the spots over their body and they will show off.
See, these are all the, this is how convincing physiotherapists are.
She comes.
She has learned by experience. But what happens is, there is a lot of talking. Cupping is a part of acupuncture.
Yes, yes.
And it has got that aura and lure of something metaphysical, something exotic, something you do not know is far more fascinating than what you can explain very scientifically. So ये तो mundane है, needling वगैरह. But cupping or even moxa, when they do moxie, there is a thing called moxie bastion, where they take a particular type of a leaf or grass or something like that, and they apply that heat. It's basically hot fomentation, nothing more than that. They call it moxie bastion in acupuncture. So that also will have lot of aura about it. So that becomes more believable. But if we were to take a group of athletes and as a study, they'll have to be volunteers that we just do once a month or once in 10 days, once in 15 days, whatever it is. They are not coming to us for pay, but they are coming as a routine kind of a maintenance. Are they able to perform it? That they will know they know subjectively. There may not be anything much to show objectively, like can they run faster? You know, they are not sprinters. A footballer is not a sprinter, but he has to sprint extremely fast at a particular given time. To judge their performance in that particular thing is very difficult. Only he will say, or maybe his coach will know that, ha, ये आज थोड़ा ज़्यादा ही भागा या ज़्यादा तेज भागा, something like that.
And it all depends on the actual, because how much warming you do, how much exercise. you do
Exactly.
before the actual.
All those you will have to keep it steady. You will have to keep them. No, they cannot be variables. In a study like this, those cannot be the variables.
Result depends on all these factors.
Yeah, no, you have to regularize all this as a part. If you are doing a study, you have to include it and see that it
Lakshmi,
is.
Madam, another thing about population.
Okay, shall we go off and speak?